Okay, so clinical monitoring of dental implants. Routine monitoring of implants is part of a comprehensive exam and maintenance and is essential to effective management of peri-implant diseases. Important data collection procedures include probing, assessing the clinical attachment levels, assess for bleeding, assess for evidence of separation, and collect routine radiographic evidence of health or disease. So probing, your initial probing depths should be collected upon seeding a final restoration. So you're going to always want to get a baseline of your probing depths. And then some surgeons may recommend postponing probing until healing is complete, or about 3 months, which is pretty typical. That's usually what we did, was we avoided probing around an implant until 3 months after the implant was placed. And then use light force with either a plastic or metal probe. So just gently probe around it, because remember, your probing depth isn't quite as important of a measurement as measuring for bleeding and inflammation. Clinical attachment levels. You must collect baseline data to use as a fixed reference point or initial probing. Probing depths may be deeper than 1 to 3 millimeters and be considered normal. So when you're probing around, you may get 3 to 4 millimeter probing depths around an implant, but one of the main things we're looking for is signs of inflammation and bleeding, or the potential for breakdown. The depth is dependent upon the thickness of the tissue around the abutment. So bleeding on probing is a good indicator of current tissue inflammation. Lack of bleeding upon gentle probing represents health. If bleeding is present, biofilm removal will reduce inflammation. When you're working on an implant, generally biofilm removal can be done with a plastic scaler. If you have actual calculus on an implant, you're going to need to use something different, and we're going to go over that in just toward the end of this chapter. Evidence of separation can be detected during probing. Radiographs. Vertical bone loss of less than 0.2 millimeters annually following the first year of function. So remember, the first year of function, you can actually lose 1 to 2 millimeters of bone support around an implant, but then it should stabilize, and you shouldn't lose more than 0.2 millimeters annually. So in other words, you're probably not going to see any significant change, because most of us can't really measure 0.2 millimeters with our bare eyes. Baseline radiographs should include the day the implant is placed, the day of the final restoration, and the day of the maintenance visit. Examine the radiographs day of final restoration placement for presence of remaining cement. So for a long time, having residual cement around an implant was a major cause of implant failure, and which is kind of part of the reason they've gone so much to using the screw-supported implant crowns, because then we don't have to deal with cement. And you should radiograph the implant at least once a year. Considerations for implant maintenance. This is the part that you really need to know about or care about. You need to know all of it, but really are involved in. Is the long-term success of the implant. Similar to a maintenance visit for a patient treated for periodontitis, meticulous patient self-care is necessary to prevent peri-implant disease. So you are going to teach the patient how to clean around this implant and keep it meticulously clean. Goals for implant maintenance, the maintenance of alveolar bone support. You want to check that yearly with radiographs. Control of inflammation, or daily self-care and professional biofilm control, usually 3-month maintenance visits. Maintenance of healthy functional implant components checked regularly and mobility checked regularly. And then maintenance of healthy and functioning periodontium surrounding the neighboring teeth must have meticulous home care. So you can't have a patient just clean really thoroughly around an implant and then have a bunch of plaque on the teeth that surround the implant, because the bacteria are going to invade. Patient provided information. Ask the patient about daily self-care routine. Ask about patient satisfaction with the functioning of the implants. Can you chew comfortably? Ask the patient perceived changes since last visit. Are you satisfied with the implant function? Are you satisfied with the implant appearance? Do you feel any parts of the implant feeling loose? Do the gums bleed when you brush? Do you notice a bad taste in your mouth? Have you noticed any changes regarding the implant? Those are some of the questions you should be asking a patient. In dental implant maintenance visit, implants are difficult to recognize intraorally. Dental chart should clearly mark location of implants and review the radiographs ahead of the visit so you know if there's an implant. So like if you look at these pictures on slide 52, tooth number 8 is an implant. You can clearly see that there's something definitely different looking about that tooth, and you can see the crown margin. The tooth is clearly longer than the tooth next to it. That's not really the most aesthetically pleasing implant, but if you think about where the lip line hits, the lip line's going to hit right about here when the patient smiles, or even if it comes up higher to about here, you're still really not going to notice too much of a difference. On the other picture on this one on the right, teeth 8, 9, and 10 are implants. So 8, 9, and 10 are all implants, but you can see how when that patient smiles, it's really difficult to tell which ones are the implants and which ones aren't. So oftentimes, if we don't do our homework ahead of time and look at the radiographs and look at the notes ahead of time, we're going to overlook the fact that there's implants in there. Guidelines for professional recall and maintenance. So your maintenance frequency, how often should they get perio maintenance done? Intervals determined on an individual basis. A 3-month interval is usually appropriate for the first year based on individual needs. Now, some patients will want or need more frequent, but usually every 3 months is good. I wouldn't go longer than 3 months on a newly placed implant. Schedule appointments as frequently as necessary to keep peri-implant tissues healthy, and identify potential risk factors for implant failure, such as if the patient has, if the patient's diabetic or has something on their medical history that may make them at a higher risk for failure. If the patient's home care doesn't seem to be going as well as you thought. If they have bad social habits like smoking. Now, generally speaking, all of that should have been evaluated before the implant was placed, but that isn't always the case. And so you need to stay on top of that. Sometimes these things change. Maybe the patient was healthy when the implant was placed a year ago, but now they're diagnosed with type 2 diabetes or something like that. More frequent intervals if reduced bone support, inflammation, or host response due to systemic conditions. So you may have to have more frequent intervals as needed. The guidelines for professional maintenance: scratching the implant surface, use only titanium, plastic, or graphite instruments. This is a must for you as the hygienist. This is why you need to know ahead of time if there's an implant there. It's one thing to accidentally probe with a metal probe if you're very gentle. Absolutely not to use metal instruments on an implant. You can scratch the titanium, and if you scratch the titanium, you're going to make it a rougher surface, so plaque and bacteria are going to stick to that surface easier. Inspect for residuals on the implant. So you're going to look for calculus and cement or cement on the implant. Now, if you take the first set of radiographs after the implant is placed and you don't see any cement, there's an assumption you shouldn't see any cement down the road, but you can see calculus. If you do, you're going to need titanium scalers to remove that. Plastic or graphite are not going to remove calculus, or cement for that matter. Special considerations for polishing. Implant restorations, polish with a rubber cup and a non-abrasive polishing agent. Most of the time we don't really polish implant restorations. We just kind of leave them because a lot of our polishing agents are too abrasive, but you can even just use regular toothpaste on a rubber polishing cup. Do not polish the titanium surfaces. So if the patient has some exposed implant, don't polish that with any kind of polish. And then glycine air polishing. I showed you earlier what the glycine air polisher looked like. That is a perfectly acceptable way to polish an implant. Patient self-care. So what should the patient do at home? Establish an individualized self-care routine. So in other words, you're going to have to work with the patient on how it's best for them to take care of their implant. Sorry, I lost the, there we go. And keep devices effective and simple to use. So don't pile on a whole bunch of different things for the patient to do because they're not going to do them. Pick a couple of most effective ways to treat the implant and take care of the implant and work with those things. If you give the patient too many home care devices to use, they're not going to do any of it, and that's going to be worse. Let's see, care of fixed prosthetic restorations or fixed crowns. Patients tend to treat single fixed crowns as teeth. So in other words, when they have an implant and it's just a single standing implant replacing one tooth, they tend to treat them as if they are just a regular tooth, a single tooth. Modify the cleaning aids as needed. Implants have unusual contours. So implants are shaped differently. They are a single post that supports a bigger crown, so they're more shaped like a bowl with a stand on it. Versus more tapered. Care of fixed prosthetics, so fixed bridges. When they have a fixed bridge that's supported by implants, you're going to use similar things to what you would a regular bridge. You can recommend super floss, interdental brushes. If you're going to use interdental brushes, make sure that they're not wire, they're plastic coated. And then water irrigators are perfect. I always recommended a water pick or something like that for them to flush around the implant. And floss with floss threaders is always an acceptable one. They're a little bit harder to use for most patients. Water picks are a little bit easier. Care for a removable one, they should be removing them and taking care of them daily. Techniques for devices for implant care. You can have manual toothbrushes, power toothbrushes, interdental brushes, dental floss. If you use dental floss, you want to make it a thicker dental floss because a thicker fuzzy dental floss will cover more surface area. If you use like a glide dental floss that's thin and super waxy, it's harder for them to adapt it to the side of the implant. Oral irrigators, like I said, those are perfect. I always recommended oral irrigators. And antimicrobial mouth rinses like Listerine. The crown covering an implant may be larger than the abutment post, and the bulky surface of the crown contacts the tissue and then dips in to meet the post. Devices must be individualized to the patient. Most importantly, if a patient is having dexterity problems and can't hold floss very easily, don't give them super floss. Don't give them floss threaders. Something like an oral irrigator or an interdental brush would be better. So we're going to tailor, and this holds true for natural teeth and every patient, your home care devices need to be individualized. This is what we talk about a bulky crown. So if you look at this tooth right here as an implant, the implant post is a single post that's going to stick in right about here. So your floss is going to go all the way up underneath till it gets to the post. So it's a little bit more complicated than just flossing up and down like on a natural tooth where the floss would stop right about here. You've got to go all the way up. If they don't get all the floss all the way up under there, they're going to miss part of the implant. Implant stability evaluation. Implants should not have any mobility if they are osseointegrated and healthy. So at each appointment, you're going to assess for mobility. How are you going to do that? Okay, so you're going to take two dental instruments, and you're going to place them on the crown on each side, one on the buccal, one on the lingual, and you're going to slightly rock them. And then you're going to check it. So you're going to check it for mobility that way. If it moves, then more investigation needs to be done. If it doesn't move, then it's in good shape. And you're going to also radiographically evaluate it. Implant mobility indicates a lack of osseointegration. In other words, the bone and implant interface has been destroyed. You could have a loose abutment though, or loose screws. So there's different parts of the implant that can become loose. You can fracture some of those parts. This is a picture of what an implant-supported prosthesis looks like. So this is the mandible. There's 4 implants kind of squared off, and then this is the denture. So basically what you're going to do here is you're going to be replacing an entire mouth of teeth or arch of teeth with 4 implants. So you want these implants to be very sturdy and very stable because they're going to be supporting a lot of force when chewing. Oftentimes they will join those implants with what they call an implant bar. And so this piece of metal, and you can see the screws at the top of each implant. So this is the implant abutment down here. And rather than putting a fixed crown on the top, they've put this implant bar. And what's going to happen is the denture is going to sit over this, and it's going to snap over this bar in a few places to keep it supported onto the implants. But the patient needs to be able to get to these implants and clean them. So usually the patient can pop that denture off, and they can take their cleaning devices and clean their implants really thoroughly. They can use an electric toothbrush, and then they can go around like in this picture with some floss and clean around the implants, flush it with a water pick or whatever it is you gave them to keep these clean. And then they're going to clean the prosthetic device as well. So they'll brush the removable denture, and then they'll go ahead and pop it back on. This has become a much, much more common procedure that they've done because it works very nicely for patients. It gives them a lot of stability, a lot of their chewing power back. It's strong, it's sturdy, patients love them. And you will see more and more of these probably during your time of practice. So that concludes our discussion about Chapter 9.